gosh, there's somebody with what looks like the Northern Lights behind them. It looks absolutely wonderful.
Yeah. Alison, yeah.
Oh, that's
Brilliant.
that.
I might just wait a minute or two, because people often do join a bit later, don't they? I think I'm going to start, actually. What do you think?
Yeah, why not?
I reckon go for it.
It's,
Okay. All right.
Let's go for it.
Let's do it. I think I'm live. See how many people we've got. I think we've got, well, people are coming in on time. So I'll start. So welcome everyone. I'm Nick Pearl, the Chief Exec of the Society of Occupational Medicine. Welcome to this Zoom webinar seminar to support the mental health and emotional well-being of clinicians on the front lines. So this is in case you're in the wrong place, this is a 2-hour seminar for doctors, nurses, students, other healthcare professionals, health system leaders to delve into the critical needs, priorities and emerging strategies to support the mental and emotional well-being of clinicians on the front lines. And we will have discussion after our speakers. I've got opportunity for half an hour Q&A and a discussion on sort of what works. Particularly need to kind of just understand what interventions work, but also understand that as much as there's stress out there from the COVID pandemic, it shouldn't be necessarily a catastrophic moment. And as Neil Greenberg will say, it's an opportunity for growth. But hopefully by the end of it, we'll have some idea of what we can do to improve morale. I mean, it's a critical issue now, and we were approached by the BBC. Kevin Teoh talked to them about this issue, and we're very thankful to Professor Neil Greenberg, who issued a report from our mental health group on sustaining mental health. That was produced with the Royal College of Psychiatrists and CIPD, so do look out for that. We're kind of promoting it on social media. So just kind of a reminder for, imagine most of the audience will be occupational health practitioners. And I suppose as practitioners, you all know how to advise and support clients on being and staying well, maintaining good health, and enhancing your well-being and productivity. And there's fact sheets and training packages everywhere to improve well-being and reduce mental health issues. So you might be delivering those interventions, or have done, or seen that firsthand, the harm that can be done when employers are not doing enough to support mental health and well-being. But often we forget about ourselves, and we know, as I'm sure Gail and Kevin will talk about, that people working in healthcare are more prone than the general population to experience mental health problems. So despite our knowledge working with others, perhaps our profession needs to be better at promoting mental well-being for ourselves. Certainly at the moment, there's some people have got very heavy workloads, lack of resources, financial constraints. Other people perhaps are furloughed, haven't got much on, and those can be pressures that can be good and bad. And there's exactly the same as the employees that you're supporting and advising. So we need to recognise when we're feeling overwhelmed, struggling, or experiencing stress, and have kind of coping mechanisms, and monitor our own coping mechanisms, so we can sort of respond to those proactively and maintain our own health and wellbeing at work, be that in-house case management clinics, health surveillance, or wherever in the workplace you're working. I mean, key issues that we are reflecting on the moment is particularly Black and minority ethnic issues, bullying, harassment, and particularly just finding out good practice, because there's lots of interventions, and sorting out the wheat from the chaff is very important. I put out on chat from some links that some work Professor Kinman and Dr. Teoh have done in terms of looking after doctors' mental health. That was in BMJ Opinions, and supporting the well-being of healthcare workers during and after COVID in the Journal of Occupational Medicine, the SOMS journal. And of course, they did a report on UK doctors' mental health. And I'm sure Neil Greenberg, who's written extensively on this issue, was also talk about his publications, for example, brilliant publications on moral hazard that's been picked up by a variety of leading journals. So they're going to talk for 20 to 25 minutes each. First off is Professor Gail Kinman at Burnout University, and she's going to talk about the existing clinician burnout crisis prior to the COVID-19 pandemic. So over to you, Gail. Thanks very much.
Can everybody see my slides? Yes? Right, so as Nick...
No.
Sorry?
No, we can't actually, no.
Oh,
No.
hold on, where are we? Display settings.
That's great. Nice one.
I didn't double click, so I think that's the problem. Hold on 2 seconds. Okay, yes?
Yeah.
Right. Sorry about that, everybody. Right, thanks very much, Nick, for the introduction. Now, obviously, we do know that the current pandemic is causing extreme demands for healthcare professionals. But I'm going to be talking about the position actually before the pandemic. And I think you will see that healthcare professionals were actually at considerably high risk even before this extra demand has happened. So I'm going to be looking at the burnout crisis in healthcare professionals, causes, consequences, and management. First of all, looking at what is burnout and how does it actually show itself? What are the signs and the symptoms of burnout? Then looking at the particular risks, the occupational risks, the organizational risks, and also the risks inherent in the individual. Then asking why healthcare professionals are actually at greater risk than people working in other types of job. Then I want to focus on the wider impact of burnout, for patients, etc. And finally, just a little bit on how can burnout be identified and managed. But I know that Kevin and Neil will be picking this up more specifically in relation to COVID in their talks. So first of all, I want to start by just showing you some findings from the recent labour force survey that we know that of all the types of work-related health problems, stress, depression and anxiety related to one's work accounts for 44%. So it's clearly a particular problem. And we know that stress, depression, anxiety related to work is responsible for a huge amount of absenteeism, as you can see from the figures here. But we also shouldn't forget that in healthcare professionals, there is a higher risk of presenteeism, i.e. continuing to work while you're sick, than absenteeism. And it is known that this is a particular problem for the future health of professionals and also the service that they're able to provide to patients can be compromised. We know that healthcare workers are at particular risk. And, for many years, every year practically that the labour force survey has been published, health and social care workers are pretty much the #1 risk profession. And we know that stress is a primary reason for wishing to leave, stress and burnout. So clearly, we do need to do something about it. So thinking about now, what is burnout? Now, it's been defined in lots of different ways. But I'm going to be looking at the Maslow definition of burnout, which recognizes that chronic stress can have particular problems on people's well-being. So it's defined as a state of mental and or physical exhaustion caused by excessive and prolonged stress in those that do people work. Now, we do know that people doing other types of job can burn out, but this is specifically focusing on those that do the so-called helping people types of jobs. So acute stress, we know that this can have positive effects on people's health. The immune system can be functioning more effectively when people are experiencing acute stress, but over time, chronic stress can be damaging. So we can explain burnout by looking at the stress response, where people are initially aroused, you know, in terms of their physiological and psychological responses. Then they engage in a stage of energy conservation where they act by trying to compensate, you know, perhaps by working harder. Then, of course, over time, they go into a stage of exhaustion where they're aware that something is wrong and they experience an array of physical and psychological health symptoms. And at this time, there can be a very profound need to escape. And some people may engage in suicide ideation, where they don't necessarily want to end their lives, but they just want it to stop in some way. And over time, this cycle can actually lead to burnout. So myself and Kevin were lucky enough to interview Christina Maslach a few years ago, and she developed the burnout construct. Well, sorry, she refined the burnout construct after interviewing people working in human services. And what she found was there was a sort of cycle of particular responses that people experienced if they were working in human services over time. First of all, they would start with feelings of emotional exhaustion, where they would feel overextended, their emotional and physical resources would be drained. Then, in order to protect themselves, they would start depersonalizing people that they worked with. And, you know, this was a phase of disengagement from the job, you know, a revision of values, etc. Feelings of cynicism, seeing people as a mass, you know, they all want something from me that I can't provide. And, you know, a feeling that you're not really engaged in this helping role and you're alienated from other people. Now, most people go into this type of work because they want to make a difference. And of course, if you feel depersonalized, you're depersonalizing people, you feel that you no longer are able to make a difference. So this leads to a decreased sense of accomplishment, where people may experience a poor sense of achievement, you know, they don't enjoy their job any longer. And because their sense of self-worth is so deeply engaged in the job, they will feel, you know, this low sense of self-worth. And, you know, they're wondering what they're doing and if they're actually having any value to the people that they work with. So that's the Maslach view of burnout. Now, more recently, Demaruti has come up with a complementary view of burnout, where it's seen as the opposite of engagement. So, you know, you have a continuum where there is extreme burnout at one end and you have extreme engagement on the other end. So we have 3 dimensions, which, you know, can be mapped on to the Maslach view, where, you know, people are high in exhaustion and low in vigor, which is, you know, energy, etc. High in cynicism and low in dedication, you know, which is the enthusiasm and inspiration that you feel for your work, and a reduced sense of competence, where, you know, they're not absorbed or engrossed in their work. And, you know, some quite interesting research has been done using this conceptualization of burnout in healthcare professionals. So what is burnout really? Now, Christina Maslach would say that it is not a disease, it's a logical reaction to untenable working conditions. And this idea that we could see it as an official diagnosis, you know, by the World Health Organization is very, very problematic, because it risks pathologizing people who are unable to cope with these untenable working conditions. So the World Health Organization initially recognized it as an official disease, but have subsequently reviewed this and, you know, are now seeing it as a reaction to untenable conditions. So what about the prevalence of burnout in healthcare? Now, all the evidence suggests that healthcare is a very high-risk profession for burnout, and certainly, you know, there's a lot of reviews of the literature out there, and we can see that up to 8 out of every 10 doctors and 7 out of every 10 nurses show signs of burnout. And there is some evidence that it is increasing. Now, bear in mind that this research was conducted before the pandemic. So I think, you know, we do obviously need to take these figures with a pinch of salt, and we need more recent research. So burnout does seem to be increasing, especially in lower to middle income countries. The prevalence depends on definitions, and I think it's very much like stress in this degree, that, you know, burnout can be defined in lots of different ways. And it also depends on how it's assessed. So a recent review, as I'm showing here, found at least 142 unique definitions, and I think that's quite interesting. And it does suggest that we need to be fairly tight in how we define the burnout concept. There is some evidence, again pre-COVID, that certain specializations may be particularly vulnerable. Now, GPs, people working in critical care, and nurses who work in dementia care. Now, these types of jobs can be particularly emotionally demanding, so that may be the reason why. We know that emotional exhaustion is a particular problem. So, you know, all the research suggests that it's emotional exhaustion that is higher than the other aspects of burnout. And indeed, people work very hard to make sure that, you know, they do not become cynical, they do not show depersonalization, etc. So emotional exhaustion is a key issue. And I think, you know, the original idea that burnout occurs over a longer period is definitely questioned by recent research, because there is strong evidence now that many are burning out early. And studies of trainee doctors and GPs, newly qualified staff, are showing signs of burnout. But there are some concerns, you know, showing in the research that people at an early stage of their job don't really have much awareness over the signs and the symptoms of burnout. So I think that suggests that people do need education as part of their initial training on what to expect from the signs of burnout. So I'm now going to look at the different types of changes that people can experience, you know, and as clinicians, it's really important to be able to pick up these perhaps initial signs that somebody may be experiencing burnout. So we have cognitive changes like difficulties, decision making, you know, even things like minor decisions. What am I going to have for dinner, etc. That's very, very difficult to do. There's an increased cynicism and suspicion of others that you work with, suspicion of their motives. People may ruminate over these minor offences, you know, and nurse these offences to them, or any kind of perceived slights that may not have been meant in any way. Doubts about their competence, you know, this notion of imposter syndrome may be particularly common in people who are burning out. And there can be intrusive imagery, but that tends to be focused and linked to vicarious trauma more specifically. We then have a range of emotional changes that can occur. Now, you know, they can be very broad and very varied depending on the person, whereas one person may be experience decreased emotional sensitivity and emotional blunting, whereas another may be more emotionally labile, where, you know, they'll burst into tears for any particular, for something that seems to be fairly minor. So emotionally highs and lows, if you like. Anger, hostility and frustration, feelings of anxiety and fear. A particularly common symptom is a sense of meaningless and emotional emptiness. And, you know, I'm sure you'll agree that people who are doing this type of work, they're often very committed and deeply involved in the job. But if they're feeling a sense of depersonalization for others and cynicism, you know, the feeling of doing a good job is not going to be there. So a sense of meaningless may be very strong. Similarly, disillusionment, feelings of inadequacy and guilt. And it's very common for people who are burned out to say that they feel trapped. So even when opportunities to change their situation, like perhaps, you know, a new job comes along, they feel paralyzed, you know, and unable to actually apply for that job or make any kind of difference in their lives. Then we have a set of behavioral changes. Now, a strong need for rest is particularly common, but unfortunately, so are sleep disturbances. So, you know, we have a cycle then of a desperate need for rest. Self-medication is very common via alcohol and particularly drugs. A decreased sense of humour, irritability, feelings of a lack of empathy with others, which can lead to avoiding contact with other people and a sense of distancing. Now, all of these things tend to conspire to reduce opportunities for social support. And of course, we know that social support is one of the greatest buffers of stress and the stress reaction. So, you know, that then is going to insulate people away from contact from others, which can compound the problem. Individual differences. Now, you know, there are a host of individual differences that have been associated with the risk of burnout. We can look at personality. You know, people who are more neurotic, people who are more introverted tend to burn out more easily. People who are type A, people who have low self-esteem, low hardiness and low resilience. Particularly linked with burnout is this idealism. And, you know, some people that go into health and social care have a so-called rescuer personality, where they feel emotionally responsible for the well-being of others. Now, this can predispose them to burnout because they're so involved in other people and their role in perhaps saving them. Overcommitment and over-involvement to the job role, you know, where their job provides a strong sense of meaning and they may have fewer outside interests than the job. And there is some evidence as well that people who live alone may be more likely to be at risk of burnout because they're not able to get that support and perhaps that perspective that we often need. Over-involvement with patients, people who have weaker boundaries between themselves and others. And of course, poor work-life balance, where they ruminate excessively about work and they experience conflict between the time spent working and feelings of strain related to the job will limit their respite and recovery. Okay, causes of burnout. Now, I think it's important to say that, you know, we've seen so far the individual causes of burnout, but there's a lot more evidence for organizational causes rather than occupational causes. You know, looking after patients and patient care does not tend to be the key cause of burnout. What it tends to be are things like long working hours, shift work with little respite, etc., a high workload, high intensity, and also role overload and conflict, low resources in terms of staffing and energy. You know, we know that obviously resources in healthcare are very low. And I think two models of work-related stress are important here, and they have been shown to predict burnout in healthcare professionals, where jobs that combine high demands with low control and support, they tend to be, you know, more typical burnout type of jobs. And jobs that involve an imbalance between the efforts that people believe that they put into work and the rewards that they get. So these are jobs combining high efforts with low rewards, not just from pay, but for things like, you know, esteem and respect, job security, and a sense of meaningfulness. Now, if anybody wants any more information about these models, please get in touch. So why are healthcare professionals at greater risk of burnout? You know, really good question. We know that healthcare is a high stress profession. And as I said in the previous slide, it has high demands and poor resources more generally. Staff are regularly exposed to the pain and suffering of others, you know, often without respite. People need to sustain a high level of commitment and intrinsic motivation to do the job. They also need to sustain compassion and appropriate empathy, where they show concern for others, but that doesn't spill over into distress. So, you know, this notion of emotional labor, the management of emotions that people have to engage in, deplete emotional resources, which can make them, you know, all too at risk of burnout. And I think very importantly is that personal sacrifice is often seen to be the culture. And, engagements in self-care can often be seen as, a luxury. So that can be a very major risk factor for burnout. So I'm just showing you a typical trajectory of somebody who you may see who is at high risk of burnout. So we have the high expectations leading to the pessimism and perhaps early job dissatisfaction when they realize, the realities of the type of work that they're doing, leading to a sense of isolation and withdrawal and disengagement, and then a sense of detachment and health breakdown, which you may find useful. So what about patients? We've looked at the implications for individual healthcare professionals, but there is quite serious implications for patient care. And some studies have found that clinicians who are experiencing burnout tend to engage in more errors. You may have links with an increased incidence of patients falling. And there is perhaps some early evidence for higher mortality rates, but I think, much more research does need to be done there. It also manifests itself in the quality of patient interaction and care, because if you're experiencing compassion fatigue or burnout and you're depersonalizing your patients, they're not going to be particularly satisfied with the service that they get. And it also has implications for patients in terms of turnover, because people who are burned out, will be off sick or leave the job or engage in presenteeism. So their performance will be compromised. It can also have implications for patients because teamwork may be impaired and communication between individuals may also be impaired. But I do want to emphasize here that all the evidence does say that staff make considerable efforts to ensure that patients don't suffer. And, we know that performance, they really do work very hard to ensure that performance is maintained until crisis point. And this can be a key problem because, they don't get any kind of support or intervention until a very serious stage. So just very briefly, because I know we haven't got very much time left, going through a set of interventions from the type of organizational strategies that can be put in place. Clearly, identification is important. Risk assessments using tools that are fit for purpose, validated measures of burnout. Considering the human cost of healthcare work and how it's managed. Now that is a fundamental issue, and the risks of burnout inherent in the job. Primary prevention, doing audits of key risk factors using the Health and Safety Executive Management Standards approach, where you can look at the factors that underpin burnout and work-related stress, like high demands, low control, low support, etc. Making sure that the contribution that people make is recognized via appreciation, regular appreciation. A culture change, well, clearly that, that is harder, but that is obviously necessary in terms of prioritizing self-care, putting on your own oxygen mask before trying to help others. Proactive occupational health initiatives, where occupational health professionals can work with managers, to put things in place to ensure that organizations are not at such a high risk of burnout, and obviously support and mentoring schemes. Secondary prevention. Now, we know that the Health and Safety Executive and the CIPD together have developed a set of management competencies, and it's a really, really good tool where managers can assess the extent to which they possess the skills that have shown to be important in supporting their staff's well-being, and helping organizations put on a set of evidence-based initiatives, like an individual toolbox that they can select the most appropriate, for their needs. And obviously the occupational health team is key to treatment. Interventions in terms of individual strategies, well, people need to be aware of the risks of burnout in their job and the early signs. And there is some talk that perhaps some sense of embitterment, you may well have come across this notion of embitterment, and that may be a very early stage before burnout, fully blown burnout kicks in. So self-assessment is key. Primary prevention, engagement in stress management, resilience training, ensuring that work-life balance is optimum, and encouraging revisions of behaviour. And for those who have problems developing clear boundaries between their work and their personal life, encouraging ways of distancing from work when required. Secondary prevention, a set of self-care toolbox strategies, things like mindfulness, practical things like time management, and the ability to switch off and regulate emotions. And finally, treatment like, counselling, CBT if necessary, absence and phased return, negotiated with the employee, a review of the job, and also a review of the working conditions, because you certainly don't want to put people back in a job that made them so unwell in the first place. Okay, so just to summarise, what can be done? We need a blend of individual and organisational strategies. And unfortunately, all too often in organisations, they tend to focus on the individual. So it's the individual's responsibility to change. But actually, a resilient organisation will support resilient individuals. It's also important when developing interventions to ask people what would make a difference to them, rather than impose interventions. Support networks like Schwartz Rounds, peer coaching can be very useful as well. And if anybody wants some information about peer coaching, I've recently written a resource on this, which may be quite useful for you. Building a culture that encourages help seeking, and also encouraging individuals to find out what replenishes them and engage in these compensatory strategies. So finally, I think also, and this is something that's relatively new, this notion of self-compassion, it's very protective in case against burnout and stress. So if anybody's interested in looking at self-compassion and how we can assess it and the interventions that might actually be helpful, there's a website there and it's very useful, and there's lots of research there. So it's basically a bundle of, mindfulness, self-kindness and connectedness, and much more information will be on that website. So predicting success is prevention or early diagnosis, a combination of organisational individual approaches, self-recognition that nobody is immune, role models, having role models in organisations to role model the desired behaviours in terms of work-life balance, etc., and active participation of all parties. I'm just going to leave you with this notion of moral injury, and I think, I don't know whether Neil's going to be picking this up as well, but it's something that he's been working on quite a lot in terms of, before the pandemic, and this is likely to be a particular problem and a particular risk factor for burnout recently, and it's defined as a profound psychological distress resulting for actions or the lack of them violate people's personal, moral or ethical code. So it's basically knowing what care patients should have, but being unable to provide it because it's beyond your control. And there are some high risk factors under the current pandemic for employees, particularly if they are experiencing these particular problems. And finally, I just want to leave you with these two quotes, and I think they're very valid in terms of burnout being the sum total of hundreds and thousands of tiny betrayals of purpose. It's not just one action or inaction, and each one may be minute, but it hardly attracts notice. So of course, it's really often the straw that broke the camel's back that will lead to a health breakdown. And we need to ensure that we know it's an occupational risk factor, but we need to ensure that any damage is temporary and people will succeed in their struggle to restore their emotional integrity. Okay, thank you very much. There are some resources here, extensive resources for anybody that's interested in knowing a bit more about it.
Thanks very much, Gail. That's fantastic. I don't know whether it's normal to experience if someone goes through a presentation, you know, in a kind of slightly sort of humorous way. I feel all the things that you express in terms of, you know, I don't know, sort of anxiety, euphoria. So you took us on, I went on an emotional journey with you, but
Thank you.
now I feel very sort of able to introduce Kevin. Unless there's any questions, I mean, do put them in the chat. I'll just check in the chat if there's any questions for you.
I'll have a look as well. Well, I'm happy to pick up.
I can't see any.
Or anybody can email me if they've got any more specific questions or they want more reading. So
Brilliant.
Okay.
Okay, right. Well, thanks, Gail. Well, we'll move on. We're moving along nicely in terms of time. So I'm going to pass over now to, I mean, Birkbeck's turning into this kind of hotbed of fantastic occupational psychologists and academic excellence, along with King's, of course. Don't want to get into academic competitiveness, but it's very nice to see that there's a kind of group of particularly occupational psychologists, but others working in Birkbeck on occupational psychology. And you know, I know Gail was joined recently, but there's many others too. So Dr. Kevin Teoh is at Birkbeck and is now going to kind of drill in on the risks and priorities around COVID and what we've been through, and continuing to go through in terms of supporting the well-being of clinicians, so bringing us bang up to date. So over to you, Kevin. Thanks very much for being part of this.
Okay, hi everyone. Thanks, Nick, for the introduction, and thank you all for giving up some time to spend this couple of hours with us. So as Nick was saying, I'm Dr. Kevin Teoh. I'm a lecturer in organizational psychology at Birkbeck. So by background, I'm an occupational health psychologist, and essentially I'm interested in how workplaces are designed, organized, and managed, and what impact that has on the mental health of workers. I'm also on the executive board of the European Academy for Occupational Health Psychology, so I'm really quite interested, particularly in working at the policy level of things. So my contact details, email and Twitter are on the slide in front of you. So at any point, as Gail was saying as well, if you want to get in contact, you know, feel free to do so. I'm going to move to the next slide. Appears my slides have gotten stuck. All right, then I think we're correct. All right, so great with technology issue and talk about, you know, having a stressor. So what I wanted to do in today's session is essentially build on from what Gail was talking about, what the healthcare workforce was experiencing pre-pandemic, and to set the context a little bit about what might be going on right now, identify some of the risk factors, and I think priorities more around thinking of, well, what are things that we need to be aware of, what we need to be mindful of, and some of the nuances in terms of understanding this context and this environment that we're currently finding ourselves in. And in front of you, you should see basically a graph, and basically this draws on a lot of work which is done around disasters, and that includes pandemic. Although clearly I don't think we've been in a pandemic very much like the one that we're going through right now. But what it covers is basically how we as a population overall react over a period of time, both pre and post disaster. And as you can see, pre-pandemic, we've already had all the issues that Gail covered, you know, higher levels of burnout, poor working conditions, and so forth. And then when we've got this outbreak, when it all happened, we see this sense of cohesion, this heroic nature, this honeymoon period, you might even call it. And there was this sense of shock. of panic, of anxiety, but I think corresponding with that, you see a lot of this idea of, we're trying to get ready, adrenaline pumping, adrenaline rushing, trying to get things done, focusing on our attention of what needed to be done, and just being very task very task driven in terms of what we needed to do. So we're talking here then, about building a community, about supporting each other, making resources available, maybe reducing bureaucracy and red tape, and like I said earlier, just trying to focus on getting things done. And there's almost a sense of a high point for some, or even for many, because you're focused, you've got very clear role in terms of what you're doing, and you know what you're doing, you're being resourced and you're being supported to get that, to get those tasks done. And this period, can last typically for a few weeks, and I think it's arguable that perhaps we might be past that right now, and perhaps entering into this disillusionment phase where there's this drop in terms of our emotional reactions and response to what's going on. We might start to realize the shortcomings in terms of the preparations and the actions that we were doing. This sense of optimism and high that we might perhaps be feeling, that might turn into feelings of stress, into anxiety, disencouragement with everything that had gone on, that is going on, that we think might be going on. And then of course there's this physical toll. Everything that happened in the past few weeks and months, that takes a toll on us, and I think then we start to see these manifestations perhaps of poor mental health, of poor mental well-being, and of individuals starting to show that they're struggling, starting perhaps to acknowledge that they're struggling. And also there might be this gap then in terms of what's going on between what we need to do now and also the resources that we might have. Perhaps some of the resources to support the availability that we had before, we might not have anymore. And particularly when we're talking about, business returning to normal, whatever that might mean. We're offering services as we've done before, but we might not have the appropriate levels of staff or finances or funding. So what are the implications of that? And this disillusionment period essentially can carry on for months and even years, actually. And there are various sort of trigger events along the way, things like anniversaries. In this case, we talk about perhaps a second wave, a third wave, local breakouts perhaps, or even government actions, inactions, announcements, policy, all can have or can elicit a reaction where we might then see a drop in terms of, that emotional, our emotional reactions, and also how we might cope and recover from this. And then on the back of all of that, looking forward, we're then looking for a period of reconstruction where we're talking about, well, how do we rebuild? How do we come back from all of this? How do we adjust to whatever this new normal might be? And then I think recognizing all those different phases, I think now we're then talking about, well, what do we know about the mental health and well-being of healthcare workers going through the current pandemic? And I think Pepper and colleagues just quite recently came out with a systematic review and meta-analysis that provided an overview of studies that have looked at these sorts of measures pertaining to COVID-19. And as you can see on the screen in front of you, both for depression and anxiety, we're talking about probably prevalence rates of about 20% demonstrating symptoms of depression and anxiety. And with insomnia, we see higher rates, about 34%. And then when we look at some of the contributing factors, obviously there's not a lot of data for us to look at it, but we start to see some common patterns emerging. One of it is that female healthcare workers appear to be particularly at risk, and equally nurses appear to be particularly at risk when compared to doctors. And some of the early research coming out that came out earlier in the year, looking particularly in China and in Italy for healthcare workers, we find quite high levels of psychological distress, so 50 to 70%. And obviously that's quite concerning. And in the previous slide where I was showing the graphs in the different stages, well, then the question is, well, what's this going to look like long term? Quite clearly, we don't know for sure. There's opportunities. Things might get better, things might perhaps get worse. But what we can do is we can look at different pandemics. And in particular, we can look at the SARS outbreaks that we had in 2003. And here are a couple of studies which I thought I'll just give you some quick overview headline figures. And the first one was in Canada. So they looked at healthcare workers in 9 Toronto hospitals that were involved with treating SARS patients, and they were comparing that with healthcare workers with comparison hospitals who weren't dealing with SARS patients. And consistently what they found was over more than a 1 year period, you find higher levels of psychological distress, also higher levels of post-traumatic stress, and also burnout as well for those healthcare workers who are in the Toronto hospitals that were working with SARS patients. But they also found some factors that were associated with better psychological health outcomes. And I think that gives us an idea of perhaps some of the things that we should be thinking of doing if we're not doing already. So things like moral support, employees and healthcare workers feeling that they're being protected, they've got adequate training for what they're having to go through at the moment. Then the second study is looking at Hong Kong, which obviously had was hit quite badly by the SARS outbreaks. And here they were looking at healthcare workers who had contracted SARS, who themselves had been infected with SARS, and they were comparing them with SARS patients who were not healthcare workers. And on all dimensions over a 1 year period, basically they found that depression, anxiety, perceived stress, post-traumatic stress, they were all higher than compared to non-healthcare workers. And that's obviously a concerning statistic. We can unpack this and we can postulate as to why that might be, but perhaps being in an environment which reminds them of what's going on, in terms of an environment where they still have to work with some of the knock-on effects of the SARS outbreaks, that might serve as some of the trigger factors that I was talking on a couple of slides earlier on as well. And then also 1 year later, we talk about symptoms of depression and anxiety. We find quite high levels, moderate to severe levels, about 36%. And that's obviously a concerning rate. And even extreme severe levels of so in this case, depression, 4%, and anxiety, 14%. And that's something for us to all be concerned about. And well, what are the risk factors? We've alluded to some of that earlier on already. Kiseli, and this is quite a recent publication, systematic review, looking at pandemics, and this included, I think, 8 or 9 around COVID-19, although the vast majority were from the earlier SARS outbreaks, but also Ebola and MERS. And what they found in terms of the meta-analysis is that working with virus cases, patients, basically was associated with a 1.7 times higher risk of developing symptoms of post-traumatic stress and psychological distress. They will also be able to pull out some of the key themes in terms of risk factors and protective factors, and you see them obviously in front of you. So healthcare workers who are younger, who are in more junior positions, they were particularly at risk, as were healthcare workers who are parents, who are carers. If those who are experiencing or concerned about lack of practical support, those who are exposed to stigma, those were risk factors as well. And then for healthcare workers who were in quarantined, and particularly the longer the quarantine period, then that was associated with poorer health outcomes. And then protective factors, obviously clear communication was one contributing factors, as well as some of the basics. So having adequate rest, having adequate PPE, and I'll come to that in the next slide, and also basically being given practical and psychological support. So again, that gives us a framework to think about, well, what should we be focusing on, and perhaps what, in terms of identifying people who might be at risk, but also what are the things that we might want to perhaps be able to put into place. And then that moves us sort of to PPE and this idea of, well, I think if we want to talk about people's mental and psychological health, we have to make sure that the basics are being done. And I think this quote from one of the first studies looking at mental health of of healthcare workers working in or on COVID-19 wards, this is in China, and basically found that staff were saying that, we don't really need to talk to a psychologist. What we need were the basics. We need to be able to rest without interruption, and we need to have adequate protective supplies. And obviously there's been a lot of discussion around the importance of PPE in the media here in the UK over the past few months, and I think this is where this comes from. Looking at some of the relevant associated literature, this is not from healthcare workers, but from the armed forces, and this is a study which Neil Greenberg was involved in, so obviously Neil, correct me if I get something wrong. And this was looking at over 3,000 armed forces personnel who were deployed into operational environments, and quite clearly you see that military personnel who were concerned about inadequate safety materials were more than twice as likely to report higher levels of symptoms of poor mental health, and whether that's general health, common mental health disorders, also being more than almost 3 times as likely to develop symptoms associated or corresponding with a probable case of post-traumatic stress. A slightly different study. This one is here now looking at the United States, and what they did over here was in the early weeks of the COVID-19 outbreak, looking at having listening sessions with healthcare workers on the front lines, and basically asking 3 questions. What are you concerned about? What should we? What do you want? What sort of messages and behaviors do you want from your managers and from your leaders? And then what kind of support do you think is important for you? And we're able to sort of distill these sources of anxiety into 8 different themes. And we've covered some of these areas again. So we see this repetition across different cultures, across different healthcare systems. And I think just it reinforces the importance and the commonalities of these sources of anxiety and concern. But basically, again, we see PPE being a factor, concern around being exposed to COVID-19 and then taking the infection home or then spreading that in their workplaces to colleagues and to patients, being concerned about uncertainty around support from the organization, the practical issues around families, how am I going to look after my families, accessing childcare, demands around food, around transportation, around lodging, and then in a workplace setting around competence. What if I've been moved to a COVID ward, or if I'm working in an environment where perhaps I'm not as competent or not as confident. And then again around communication, having that lack of access of up-to-date communication, what's going on, and clarity. And what they're able to do again here is to kind of summarize it into 5 themes in terms of what we should be doing. Basically what healthcare workers here were saying is, well, hear me. We need to be heard. We need to be protected. We need to be prepared. We need to be supported, and we need to be cared for. So these are kind of overarching categories. And if you want to look at the original paper by Schanafeld and colleagues, they give examples of how they are trying to provide support along these 5 dimensions. But again, that's quite a useful overview framework of us trying to think about what we might be able to do in what our more local context might be. And in recognizing all of that, I think it's important for us to recognize that there are priorities, there are nuances in how we understand what's going on, and also nuances in terms of how we need to intervene. And I've kind of listed out 4 key areas over here: demographics, psychosocial working conditions, stigma, and then how we make sense of all the evidence that's out there, or that's perhaps not out there. So the first one in terms of demographics, and really what the point, trying to say over here is that we have such a diverse workforce that we need to recognize that everyone comes from a very different background, that has got different experiences, and we need to understand and we need to cater for all of this. Obviously, there's been a lot of discussions in the last few weeks around ethnicity and the experience of BAM workers, and we know that obviously those from BME backgrounds are particularly at risk in terms of poorer outcomes around COVID-19. The Guardian, I think they estimated that 60% of healthcare workers' deaths are those who come from a BAME background. And it's not just obviously healthcare workers being concerned about themselves, but if you've got family, if you're in a community, and therefore you yourself might be concerned about other people in your community, in your families, and what might happen if they get exposed. What if they get infected? What might their health outcomes be? And that's an additional source of concern and anxiety for yourself. And this, of course, also intersects with other aspects in terms of the roles within the organization. How does ethnicity fit in with the roles and responsibilities that individuals might have within it? And then again, how might we intervene in an organizational setting, but also in a wider community point of view as well? Age, again, is another big risk factor. We know in the US that there's a 1.4% higher case fatality rate if you're above 55, and if you're above 65, then that's a 2.7% higher rate. And obviously then there's concern for healthcare workers who fit within those age bands. And again, when we've got healthcare workers who perhaps might have come back from retirement or were close to retirement, they may not be working necessarily on the front lines, but how are we protecting them? How are we addressing some of their also psychological concerns and worries around working in these environments? Whether now or moving forward. Gender, again, is a big issue in recognizing the concerns that we have. Some of the issues earlier on, we see that females are particularly at risk. Nurses, again, which is a female-dominated workforce, again, are particularly at risk. So obviously that's something that we're concerned about. Some of the the issues around caring responsibilities, around looking after children, being a parent, that those burdens, unfairly and unequally distributed on the female workforce. That's something that we need to recognize and that we need to address. And that's, again, an additional massive source of stress for our female workers. And then that also then intersects with work-life boundaries, something which Gail alluded to earlier on. Even pre-COVID, female nurses are particularly struggling. They often struggle to manage that relationship between home and work, and this presents a whole different dimension to what they're already dealing with before. Then looking at the changes to psychosocial working conditions, Gail mentioned the importance of having psychosocial risk assessments, and again, this reinforces this, particularly as we move forward and the world of work and how healthcare and the work environment will change and what that looks like. We're not quite certain. Today, the BBC is reporting that I think we're expecting to have NHS waiting lists of 10 million people. So what impact is that going to have on demands? We also know that change is going to be continuous. It might be even quicker, and change might be good. It might also be bad. So how is that managed, and what impact is that going to have on our healthcare workers? And that's something, again, that we need to recognize, that how this work environment is changing, and therefore how we intervene is going to be different across different aspects of both in the NHS and also our healthcare workers are working outside of the NHS. The third priority, which I think is important for us to recognize, is that around stigma, and we could probably do a whole session around stigma, but I'm going to focus here on kind of 2 points, because I think there's 2 dimensions to it. One is stigma against healthcare workers, and obviously we've seen in the last few months there's been a kind of an outpouring of support and encouragement, which has been great to see in terms of encouraging our healthcare workers. The whole Clap for Carers on a Thursday. But I think on the back of that, it's also important to recognize that there has been also stigma and ostracizing of healthcare workers, of nurses and paramedics being asked to leave accommodations and lodgings because people were concerned about the spread of the coronavirus in other countries. Healthcare workers have been assaulted, and that's something to be concerned about. And we know from earlier pandemics around Ebola in particular, where healthcare workers again have been stigmatized. And I think looking forward, depends, I guess it depends on how we emerge and how we come out of this pandemic. And it may be that as society perhaps moves on, but as elements of the healthcare workers are still working, whether it's second or third waves or local outbreaks of COVID-19, how are they going to be treated, and how are they going to be responded to, that they are struggling and the rest of society has moved on? How are they going to be, treated? And then the second aspect in terms of stigma revolves around stigma of healthcare workers seeking support. And again, that's been an issue that we know from before, where healthcare workers have often struggled to ask for help. There's perhaps been fear of the regulator, fear of being seen as incompetent in their work. This myth that a sick doctor or an unhealthy doctor is a bad doctor, which obviously isn't true. So how are we going to encourage individuals to reach out and get the support that they need? And equally, I think there's been there's been this very strong hero narrative around healthcare workers, which is done with really good intentions, but I think that's also anecdotally led to feelings of healthcare workers saying, well, people hold me up in high esteem, and I don't really want to say that I'm struggling because I don't want to let my family down. I don't want to let my community, my peers down as well. And I think we have to recognize that. But of course, on the back of everything that's been going on, there's also, with everything, there's positives and negatives, and it has created a space for us to talk more openly around mental health, and there has been a lot of support and resources and goodwill made available to try and support and encourage the mental health and well-being of our healthcare workers. And the final priority that I wanted to cover was around evidence. And this is quite a complex thing, and before this webinar we were talking between myself and Nick and Gail and Neil as well, how do we make sense of all of this? And we could argue and say, well, COVID-19 is different to all the other pandemics that we had before. We are drawing on information and evidence that we have from those. We're also drawing learning from other disasters, whether that's natural disasters and or terrorist attacks and so forth. But the context is different. So how do we recognize those nuances? How do we fit those to understand what's going on, and then how do we appropriately intervene. And even then, sometimes there's a lack of clear consensus, and obviously one of the clear examples around that is the role of psychological debriefing. Is it appropriate? How do we do it? And Neil will cover, I think, some of that in a little bit more detail in terms of his presentation that follows after this. And the other one, I think, and this is that the second quote that you see in front of you, there's been so much evidence coming out and data being collected around COVID-19, surveys being carried out. How do we make sense of all of that? How do we synthesize all of that information? And also, amidst all this rush of trying to understand what's going on, are we perhaps at risk of collecting data or carrying out studies which might not be of the quality that we would normally have in a pre-pandemic situation? And that might be appropriate given what's going on, but then we need to recognize the limitations of and the nuances again of what's going on. And you know, in our discussions before this, we were saying that there's issues around sampling bias. If we're talking about mental health outcomes and giving surveys, those who are struggling, those who haven't got time with everything that's going on, they might be the ones who actually haven't got time to fill out surveys, to share their experiences, and therefore aren't actually capturing any of the information that we're collecting right now about COVID-19. So basically, to summarize and to conclude, you know, I think we have some understanding of what the risk factors are, and that comes from some of the early research around COVID-19, but also from other research from pandemics and disasters. But I think there's a lot of things that we need to focus on, and these include, but not limited to, demographics around healthcare workers, recognizing the psychosocial working conditions of healthcare workers, stigma, and whether that stigma that healthcare workers have on themselves, but also other people towards healthcare workers, and then trying to make sense of the available evidence. So, you know, I hope I've given you a lot to think about, and I guess that kind of leads on to the next question is, well, what do we do about all of this? I've kind of left this a big question mark, and I'm going to pass over to Neil, and I trust that Neil's going to fill in a lot of the gaps over here. So, yep. Thank you very much.
Thanks very much, Kevin. That's a fantastic presentation. It's all going very nicely, isn't it, between looking back and what the evidence was with Gail, where we are now with you, and now moving to Neil Greenberg, who's Professor of Defence Mental Health at King's College London. He's going to talk about actions and interventions. And also want to very much welcome Neil as a new trustee of the SOM board, which is fantastic to have someone of his calibre. And also his work, as I mentioned at the start, with us and the Royal College of Psychiatrists and CIPD on sustaining mental health. Do follow him on Twitter. He's even more active than me, and really interesting. And this is a critical moment, and actually what he's saying on Twitter and other social media is really worth looking at. So over to you, Neil. Welcome.
Thank you very much indeed. Is my screen up?
Yes, it is, yeah.
Yeah, great, okay, and you can see I have a large planet behind me because obviously it's so infectious on the Earth. I decided to try and go to an interstellar location. Thanks for asking me to speak, and hopefully I'll try and bring together some of the great work that Gail and Kevin have spoken about, and try and sort of put it into an evidence-based plan for what could be done both now and also sort of going forward, because we may have a second wave, and whether we have a second, third or fourth wave, everyone seems to think we'll definitely have another pandemic at some point. Yeah, obviously something to look forward to, I think. As I've had an introduction, so basically my kind of interest in healthcare workers and mental health at the moment sort of comes because I'm really interested in organisations and mental health. I do lots of different bits and pieces that I won't go through, but when this all kind of started, I've been sort of dragged in to be part of the NHS England and Improvement Wellbeing team. I also got asked to set up the mental health strategy at the London Nightingale Hospital that probably be aware sort of ran for about 5 or 6 weeks, which is quite an interesting sort of approach, trying to sort of sort this from scratch, trying to look about what the evidence says might work. And I'm part of an expert reference group for Public Health England and also for the Department of Health and Social Care. I mention that just because whilst I don't have any sort of detailed knowledge that I can share with you that you won't already know, what I think's been really interesting is that there's been a great desire to try and look at what evidence is out there in order to try and inform practice. And in my experience, you know, some of the time that does inform practice, and other time it doesn't, for reasons that you're probably more than well aware, with political agendas and the like. In terms of information that I'm going to speak about, these are 4 different areas that you can go to have a look. Just worth saying that most of the papers are meant, I will mention that I've been involved in, will be downloadable at this website. But also our Health Protection Research Unit at King's College London has now updated its papers. We got dragged into doing so many things that we didn't have time to update it. But there is on this website most of the sort of more contemporary papers that I'm going to mention are there. It's worth saying that our Health Protection Research Unit, which is funded by the National Institute for Health Research, it's been running for about 6 years now, and it's set up to try and look at pandemics and disasters. So this, unsurprisingly, many of the team there have been dragged into various sort of governmental committees, and so I think we're doing a lot of great work. Some of it able to publish too. So if you're looking at a group of people such as healthcare workers, and you had time to prepare for what was coming, which I suppose probably sort of when we started looking at this in February and March, there was time to prepare. There's a number of things that the evidence says can make a difference. And we wrote a paper back in March, which went into the British Medical Journal, particularly sort of looking at this topic of moral injury that Gail's mentioned. And our view was at the time, looking for what was happening in China and certainly in Italy at the time, was that we were going to be thrusting our healthcare workers into a situation that actually they weren't really very well prepared for. So whilst obviously health care and death sadly go hand in hand, mostly that death comes at the end of a valiant and high quality effort to save lives in most cases. And what we knew, and what to some degree has come to be true, is that many of the healthcare workers who have performed fabulously during this pandemic have had to do things that are really outside of their normal scope of activity. So we, certainly the Nightingale, what we started off by doing is when people were volunteering coming in, we asked them to check themselves before they took up the role. Now by that we meant is, are you in a psychological position where actually, if you used to be a pediatric audiologist and you now say you want to work on an intensive care unit, are you really ready for that? I mean, for instance, are you living with someone who's shielding? Are you living with someone who might be vulnerable? If so, are you going to be worried about taking the infection home? What's that going to do to your mental health? You know, have you been involved in traumas before that might get reactivated by the work you might do in an intensive care unit? Have you got lots of domestic problems going on at home? And we kind of gave people a list of things to reflect on. I'll mention screening in a second, but this wasn't screening. This was basically trying to alert people to what the psychological risks might be in the work they were going to do ahead. Once people decided that they did want to get involved, most hospitals, not just the Nightingale, had a lot of staff coming from, say, outpatients or from sort of relatively quiet departments in the current pandemic that were going to close down or have very little to do, and they pulled them into much more intensive settings. And we felt very much that one of the situations they shouldn't have to experience is making really morally challenging decisions for the first time when the patient is in front of them. So what we wanted to happen was to make sure that people who are getting into these challenging roles really understood what the nature of the moral challenge was. And we used the term that the information they should be given shouldn't be sugar-coated. And so we wanted anaesthetists, for instance, to be speaking to people who are coming to work in intensive care, basically telling them that no matter what they do, people are going to die. And that's not because necessarily you want them to die, but sometimes intensive care, particularly, you know, has a high mortality rate. And we wanted all these kind of, you know, want to save the world people coming in, really understanding that actually it's going to be difficult, and they're going to be asked to do things that they're not going to feel prepared to do. Not that wasn't to put them off, but once again, it's about really trying to make them think about these situations and discuss them before they get involved in them. Then we came up with this idea of what's called psychological PPE, which is, you know, just a jazzy word really, for a jazzy phrase for trying to think about how do you prepare people well for the tasks that they're going to do in terms of their psychological preparation. And one of the things that we thought was really important was to use something which comes from a term which is called the Wellness Recovery Action Plan. which is basically a way of trying to put together a set of personal resources before you get into a difficult situation that you can then call on when you're feeling stressed. So that might be, who do you speak to that you find is psychologically helpful and who's not helpful? You know, what do you do? What sort of exercise? You know, what film do you watch? What music do you listen to? Who do you speak to on the phone, or who do you Skype? And by making a plan that's personalized to you, when you are becoming distressed or even burnt out, as Gail was talking about, you should turn to the plan. You should say, okay, I feel rubbish, but let's do one of the things that when I was feeling pretty well, I set down that actually might help me. There was also a bit of psychoeducation, you know, telling people about the sorts of symptoms or reactions that it might have. Actually, the evidence on that's pretty poor. We're not entirely sure that warning people about symptoms is necessarily a good idea. The evidence is out. There is some school of thought, and there's some research evidence that backs this up, saying if you tell people what they're going to experience in terms of bad symptoms, well, guess what? That's what they experience. So it's a little bit less clear what you should be doing. And then, as has been mentioned already, I think Kevin mentioned it, it's really important that you have role-specific training. Our military health research studies that we've done many times in King's College London basically show that if you take someone and deploy them to a conflict zone and say that they're a radio operator, but because of what happens in the conflict zone, they get asked to be on guard duty with a gun shooting enemy who are coming in. Yes, they can do it, but that's not really what they're trained for. It's not really what they're expecting. And they are at much higher risk of suffering with mental health problems. So what we know is that giving people training to do the specific job at hand isn't just good for them to be able to deliver good care, it's also good for protecting their mental health. Now, one of the things that I haven't mentioned is about the idea of using psychological health screening. Now, this is something that's quite seductive, because if you could have screened groups of potential intensive care workers and tried to work out who was more at risk, then you would have been able to say to certain people, no, you shouldn't go and do that work because you're going to fall apart. But you seem okay, you should go into it. I have to say, lots of organisations, healthcare accepted at the moment, do use psychological health screening as an idea to try and see whether you're ready to do a particular task. Now, what's called the grandmother test is good, and I'm not sure if you heard of that, but the grandmother test refers to the fact is if you've got someone who's only going in to want to work in intensive care because they think they're going to get more money, because they've been told they have to do it, they've got sick children at home, their spouse doesn't want them to go, and they don't get on with the team they're going to work with, your grandmother could tell you that they're going to have problems. You don't need a sort of psychometric scale to tell you that. Unfortunately, your grandmother would also tell you that if you go out without a coat on in the winter, and you'll catch a cold, which, as you probably know, is not true. Not sure if you recognise this chap. This is General Marshall. He was Chief of Staff of the US Army at the end of the Second World War. The reason I put him up is that without knowing it, about doing it, he carried out a really good study on psychological health screening. So in 1939, if you wanted to join the US Army, you had to see a psychologist or psychiatrist who determined whether you were made of true grit or you had the right stuff, or whatever cheesy phrase you might think about. In 1943, they ran out of people, and so General Marshall overturned this policy, and all those people who were lacking in grit or who weren't deemed to be tough enough were made to come into the military. And there was plenty of unpleasant things that happened after 1943. There was D-Day, there was a victory in Europe, victory in the Pacific. And what they found is that 80% of them who were deemed to be weak actually went on and had a perfectly good war. So that screening was pretty worthless. We did a similar study on that in the time of the Iraq War in 2003, and we found a very similar finding, that actually trying to screen people before war, really, you can't predict who's going to have problems and who can't. And this is a paper out in occupational medicine just recently, which was done by an Australian group who we have good connections with at University of New South Wales. And they did a fabulous study where they basically looked at a whole lot of psychometric tests that are administered to recruits to the New South Wales Police Force. These tests are used to determine whether people are fit enough to become a police officer. And these tests, including the MMPI, the Minnesota Multiphasic Personality Infantry, if I say that after a glass of wine, that these tests also have validity scales in them. And they followed people up, these recruits, for 7 years, and they found that the tests done at recruitment predicted absolutely nothing, and it was a waste of time. So this idea of screening people before going into a role is very seductive, but actually is a waste of time It's discriminatory because you exclude people who could do the job pretty well. And also, I think it's dangerous in the sense that you get false reassurance that actually people are fit for the role when actually the tests mean nothing at all. So when you get people ready for the task, the next thing is how do you sustain people doing these really challenging roles? We published a paper on that. We published a couple of papers on that actually. But what we're able to do from our Health Protection Research Unit data is to draw all the evidence that we have on military, on emergency services, on disaster response, on healthcare workers who have worked on previous pandemics. Kevin covered some of that data you've seen. And we were able to try and say what is likely to make a difference to staff who are performing these challenging roles. So one of the things is to buddy up. So by that, we mean that when people are going on to shift, yes, you want people to be doing a job well and to work as a team. But what we suggested and what the evidence supports is specifically giving people the responsibility in pairs to look out for each other. So you two, I want you two to work on that bed or that bay over there. One of your jobs is to check in on each other, to make sure you're okay, and to have an early conversation if you think anything's up. And if they don't want to talk to you and you're worried, come and see me, I'm your supervisor, and let me know and I'll try and sort that out. So very much trying to give people a first line point of contact right within the team. And this very much fits into all the evidence we know, which is that social support within teams is really, really important. And one of these slightly cheesy phrases, but I strongly believe in it, and this is borne out very much by the evidence, is that resilience often doesn't lie in individuals, it lies between individuals. And that if you have very good bonds between members of a team and also between a team and their supervisors, then you've got a psychologically protected environment for everyone who's working with it. So of all the evidence, and I'll show you a bit about this in a second, that we have, we know that the most important person in a team or in an environment that to influence mental health is the supervisor. And by the supervisor, I mean the person who is on the shop floor, who is managing the shift, who is managing the day-to-day work. So that might be the lead nurse on a bay of 6 intensive care beds. It might be the lead consultant who is looking after the intensive care team on a much sort of wider scale of a whole intensive care unit. So those supervisors, the person who deals out your day-to-day work, we know that they have a huge influence on their team's mental health. And what seems to be really important is that these people have to be able to have a psychologically savvy chat. So when they say to a team member, how are you doing? And the team member says, I'm fine. You know, that doesn't mean anything at all, because fine can mean absolutely everything. What's really important is that a supervisor can get beyond that and actually have a meaningful conversation. Great study, again, actually done by the group in the University of New South Wales, basically looked at fire station managers. They trained half of the managers in an approach to mental health that allowed them to feel confident to have a psychologically savvy chat, and the other half got no training. They did a random allocation. They published it in Lancet Psychiatry, and they looked at sickness absence for the 6 months before this intervention and the 6 months afterwards. And they found that for every £1 invested in this intervention training, they saved £10 in sickness absence for the following 6 months. And the main point of that training, or the main driver of its success, was that the supervisors felt confident to have a psychologically savvy chat. At the end of a shift, rather than everyone kind of bomb bursting home and saying, okay, just go away, really important that you give people just a little time for reflection. What happened? What went on? How are you doing now? One of the reasons for this is back to the moral injury piece, is that we know that at the end of a shift, you're likely to start reflecting on, you know, did I do the right thing? Did something bad happen? Did that person do the right thing? And as we reflect on these things, we begin to create a narrative about what just happened. And that narrative can be healing, which is, you know, I did a great job and we saved lots of lives, or it can be pretty toxic, as in, I mucked up, or actually my boss was an idiot and actually I didn't have the right equipment, and if they'd done something different, it would have all been a lot better. So what a post-shift review can do is just begin to help adjust that meaningful narrative as it's beginning to set in. And that's really important, because often people will begin to reflect more as time goes on about what's happened. Really good evidence that peer support, formal peer support, makes a difference. Lots of different ways that this can be done. I'll talk about that in just a second. And then the last thing is actually the first time that actually mental health professionals like me should be getting involved. I think, as Kevin mentioned, really good evidence that you don't want people like me, you know, on the shop floor. That's not our best place. I'll mention that a bit in a second. But there's really good evidence from the military literature, also from other occupational health environments, that actually what's called forward psychiatry or forward mental health makes a big difference. So within the military, when you have troops who develop acute stress problems on deployment, the main focus of military psychiatry is to get people back to the front line because you need to conserve the whole of the fighting force, otherwise the whole battle is lost. So these PIES principles have been built up over years and years, and the Israeli military did a study on Israeli troops who were in the first Lebanon war in 1982. They had a lot of acute stress casualties there, and Zahava Solomon, who's a really big name in Israel in terms of trauma research, she looked at the number of the PIES principles that were put in place when people developed acute stress problems in conflict, and she looked at the mental health outcomes 20 years later on. It was published in the American Journal of Psychiatry in 2005, and they found that the more of the PIES principles put in place at the time that someone was distressed, the better they were 20 years later on. So this is a really good approach of keeping people at work, which is good for work, but also very good for their mental health. So the first principle is the principle of proximity. And what proximity means is that when someone's feeling distressed, rather than say, well, you just go home or go off shift, you say, well, let's support you here. Let's readjust your duties a little bit. Let's give you good support. And in the First World War, the phrase was, let's keep you within the sound of our own guns. These days, I think it will be keep you within the sound of our own keyboards or our own ventilators or whatever device you have in your workplace. Don't just send people home. Try and reassign their duties. Let them keep that social support. Let them keep their self-esteem that they're not ill and unable to function. And actually, people then do much better. Immediacy says that if someone's not doing well, rather than say, well, that's their problem, you should try and adopt a very much nip it in the bud approach. You want peers and colleagues and supervisors to be having early conversations to find out what practical problems people have and actually try and solve the practical problems. If your main problem is the fact is you think you're crap at doing this particular technique and you think you're letting people down, well, you don't need psychological care. You need someone to show you how to do that technique and to mentor you and to help you do it better. That's the psychological intervention. Expectancy is the principle that when you're having a tough time, the expectation should be that actually you're not mad, probably this will recover in time, we'll support you. And also, if it doesn't recover, the expectation is we're going to make sure you get the support you need. And then simplicity is that when people are having a tough time, practical, simple things make a big difference. As I mentioned earlier on, that opportunity to learn a technique that might be causing you stress, to learn it properly and be mentored, that might make a difference. A chance to get out from the intensive care ward for 10 minutes to phone your family to find out what the results were of your wife's blood test, for instance. When you're going home, to have 3 good meals and a good night's sleep is often the best form of psychological first aid. And these simple interventions are very much ones that we would expect to be done in the workplace, and they make a big, big difference. So that's the PIES principles. Just some data to go with that. This is from our data in Afghanistan. When I was in the military some years ago, we went out and we surveyed troops who were in Afghanistan, who were performing, challenging roles across the country. We surveyed about 1,500 troops, and what we were looking at was their perception of their immediate line manager, their immediate leader, their supervisor. So you can see here what we mean by good leadership. Good leaders, for instance, don't accept extra duties to make themselves look good at the expense of their team. They treat all members of the unit fairly. And where people scored 3 or more, they endorsed 3 or more of those things about their immediate supervisor, we said they had good leadership. In these troops, you can see that just less than 3% of them probably have PTSD using a well-validated scale. But these are people who thought their immediate leader was good. And these are people who thought their immediate leader was poor. There's a 10-fold difference in the rates of probable PTSD. So the impact of that supervisor level leadership is really, really important. And it doesn't just protect their mental health, it also makes them more likely to go and get professional support if they do happen to need professional support. So if you're looking for bang for your buck, investing in your grade 6 or grade 7 nursing staff is probably really, really important. And part of that is about having those psychologically savvy chats. Looking at peer support, or camaraderie and social support, this was a group of military personnel, actually some years ago now, who returned from the former Yugoslavia, where they've been doing peacekeeping duties, full of morally ambiguous situations in peacekeeping environments. We said, who did you speak to about your difficult experiences? 97% said I spoke to people who had the same experience as me, who knew the same language, who knew what I was talking about. Only 8% went to speak to medical or welfare services. So many hospitals have said, oh, we have employee assistance programs, and that's fabulous, but that's not where most people go. And as you probably know, with employee assistance programs, the uptake for those is sort of usually in the region of 4, 5, 6, 7, 8% if you're lucky. So what you really want to be doing is making sure that the support from supervisors and colleagues is really, really strong. When you look at peer support, this was a paper we did 8 years ago now, published in the Journal of Traumatic Stress. And this was a Delphi study asking many experts in trauma and peer support what they felt are the key criteria for what a peer support program should do. And they came out with these 4 things: that peer supporters should provide an empathic listening ear. These low-level psychological interventions are not ones to do with cognitive behavioral therapy, or like these are simple things such as giving people a phone to phone home, such as advising them to have some have a meal and to take 10 minutes out. Very practical based things that make a big difference. To be able to identify people who may be more at risk, and also where people do need professional help, the peer supporters should be metaphorically putting their arm around them and saying, come on, we need to go and get you to go and speak to someone who's got a mental health background. One of the programs, and there are other programs for sure, is trauma risk management, which is a peer support program that I've very much been involved with over the past 20 years. Started in the military. A paper published in Occupational Medicine back in 2015 was a review of the literature on TRIM. We've done over 10 academic papers now on TRIM. And this is not penicillin for trauma in any way, but it seems to reduce sickness absence. It's very acceptable. It helps with social support. Improves organizational functioning, and improves help seeking. And as a peer support program, it's a very credible one, which has a lot of evidence. Other programs are ones you may have heard of called psychological first aid. Actually, Public Health England are just putting out a free psychological health aid training package online, which is something that many employers might find useful. It's promoted by the World Health Organization. I would say the evidence on its effectiveness is perhaps a little less robust, but there is evidence it seems to help the people who have the psychological first aid training. And you've probably heard of mental health first aid again, and I won't go into the evidence on that there because the jury's still out, but I would certainly say that NHS England's view is that's not an approach that they are trying to advocate. Certainly we don't want peer practitioners to be counsellors. We're not aiming to make them therapists. They shouldn't go around giving people a hug, certainly not in the current climate. And this is not a pink and fluffy thing. This is very much about trying to put simple, practical support right where you might use it, and also to have what NICE would call an active monitoring process, again, within your peer supporters who can keep an eye on people. We briefly mentioned psychological debriefing. I won't go into it for in a lot of detail. Just to say, NICE, who produced trauma guidelines, PTSD guidelines at the end of 2018, are still very clear. You should not be doing psychological debriefing. You do not want mental health professionals and trauma counsellors coming into the front line to speak to people who have been subject to traumatic events. The evidence is it does not work, and it makes them worse. So you wouldn't recommend any treatment out there that didn't work and made someone worse. It would be ridiculous. And NICE don't often say don't do something, but they were clear enough to say do not do this. And what NICE do say is you should actively monitor people and then provide them with effective treatments if they actually need care. That's what's really important. And just for any of you who are interested, one of the things you also shouldn't be doing is prescribing benzodiazepines. Good evidence that for people with PTSD, that benzodiazepines also make things worse, even though many GPs still prescribe them. And then coming on to recover, so we're hopefully in the recovery stage now. what should be done. We had a short comment paper come out in Lancet Psychiatry last month on this, and the Royal College of Psychiatrists has a plan called Going for Growth, which is the recovery plan, which is available on their website, which has got a lot of the information in more detail. First of all, there's good evidence that actually saying a proper thank you makes a difference. It shouldn't be meaningless. It should come from the right person, and it should be honest and heartfelt. It should come with information about additional resources and what's going to happen. Alongside that, people should have a graded return to work. They shouldn't stop doing COVID work on a Thursday and expect to be back to work in a busy outpatient department on a Monday. The military purposefully, when troops deploy, have a graded process which takes people away from a war zone, gives them a bit of time together, gives them time to have leave, and then prepares them over, and that whole piece is over a few weeks. And I very much think that actually, given that many healthcare workers have been going for 3 months now on this task, there should be a graded return to work for them as well. Back to supervisors, really important. A supervisor in your back to work place finds out what you've been doing, because you may well not be working with them. They need to find out what your experiences are, and also need to try and identify whether you might be in a higher risk group. That may include BAME staff that you've already heard about, Nick's mentioned, but also people who are really inexperienced that Kevin mentioned in that Kisley paper. So if you've been doing things that are either new to you or very outside your normal experience, then you're a higher risk group. Also people with secondary stressors. Again, you won't know about these unless a supervisor asks about them. What's been going on at home? Has your partner lost their job? Have you got financial difficulties? Is there domestic violence? Has unfortunately anyone in your family been killed or seriously injured by COVID? What is going on that also makes your recovery more challenging? And the evidence is that certainly with PTSD, that secondary stressors make a big difference to whether people develop PTSD or not. Back to this time for reflection, I think Gail mentioned about the Schwartz rounds. It's one way to do this. But we know that as people begin to develop this narrative, which is, I was let down and I didn't have enough PPE, I wasn't properly trained, I wasn't properly supported, that leads you down a path of moral injury, which puts you at risk for PTSD, depression, and suicidality. On the other hand, if you can come to a kind of understanding that it was the situation that was unprecedented. Yes, I didn't do everything right, but you know what? I did my best, and actually people lived because of what I did. That is a much more healing narrative. And what the important part about reflection is that it's led by leaders. And so that actually a leader can say, do you know what? I didn't get it right either. And certainly no one got it right. But actually, do you know what? We didn't do bad. And if you want to blame anybody, blame the virus. Don't blame the PPE story. Don't blame this and don't blame that. And certainly don't blame yourself. NICE have mentioned active monitoring. And what we know is that there is going to be a need to monitor people, not just for a month, but for longer. Data after the Manchester bombing showed that the screening outreach program there, that in that healthcare professionals started to come in really after a year later, because they keep on going because of the stigma that Kevin mentioned, and they won't come forward and get help. So there are plans now that NHS England are going to be putting in place an anonymous online self-monitoring tool. The anonymity side of it is important because people might use it because they don't feel that anyone's going to find out how they're doing. But it can give people an honest check of their psychological health. If you fill the questionnaires in, they're only relatively brief, it will then signpost you and give you information. I don't like the term signpost, but it'll give you information about where you can seek help. Or here's some information about your drinking, or here's some information about substance misuse services, or leadership courses, or chances to join a virtual Schwartz round. And the NHS England have made, it's called the Point of Care Foundation, are running virtual Schwartz rounds. And so there's a whole range of resources that this online active monitoring will aim to do, but it will also recommend that if you need professional care, where to go and get it. And again, NHS England have some resources in place, including a text-back service and a confidential line, but they're also putting in place both a local and a national offer so that healthcare staff haven't got to wait many, many months to access care, because that's an own goal, particularly if there's a second wave. And so when they go and get care, the last thing to say here really is that it's really important that it follows the evidence. There are likely, as there are in the veterans world, to be many very well-meaning counselling services out there who want to save healthcare staff. But what we need to do is to make sure that if people need evidence-based care, that they get that first, that they don't get into a counselling service For instance, counselling has no impact on PTSD. You can go to the counsellor for 20 weeks, have a really nice time and feel supported, but you don't get better. So we need to get people to have care that works in a timely fashion. I won't labour this in any detail, but there are lots of interesting ways to deliver care. For instance, there's an intensive CBT course, work done at King's, not my team, another team, which is basically delivering 16 hours of cognitive behavioural therapy in 1 week. And that seems to be as effective as doing it over 3 months. St George's Hospital in London are delivering that now. No reason that can't be done. What a great idea to take someone who's kind of broken, give them a week's intensive treatment, and then begin to get them back to work. You can do things remotely. There are some interesting ways of training up less skilled people to deliver care. We did a study in Sierra Leone after Ebola, which showed that works. There's some interesting virtual reality ways of providing treatment, use of MDMA along with psychotherapy, using partners to help with therapy. And the most important thing, though, is to make sure that you get treatment early on. What you don't want is people to come in 7 years later, which seems to be the average amount of time that people come to specialist trauma services, by which time they've lost their job, they've lost their self-esteem, they've lost their relationships. And actually the trauma symptoms are important, but all those secondary losses really make it difficult to help someone get their life back. So overall, the evidence says we should not over-medicalise. Many people will have distress, which will be quite normal. We don't need to give that a formal diagnostic label. We need to reassure and help them. Nip it in the bud, build team support, make sure supervisors can have those psychologically savvy conversations. Mental health professionals should be adopting a return to work focus wherever possible. People should get a thank you, a phased return to work, and some time for reflection. They should be monitored. And then, of course, there will be people who absolutely need evidence-based care, and they should get good quality care in a timely fashion. So that's me. There's my email address and my Twitter. If you follow me on Twitter, I'll pump out all the papers that we push out, so it's a useful way of keeping up to date. And thank you very much indeed.
Brilliant. Thanks very much, Neil. I looked, my video seems to have stalled, but I haven't seen any questions in the chat. I'm wondering whether people want to unmute themselves and ask any questions. Anyone want to ask any questions? I can see a variety of occupational health people on it. Any reflection?
I'll ask a question of Gail then, just to be difficult to start with.
Okay.
Only because she went first, so that was unfair. No, so how do you think that how should the NHS persuade senior healthcare managers to kind of take proper account of their staff's mental health? Not because they don't want to, but because there's now, as I think Kevin or you mentioned, there's sort of predicted to be 10 million people on a waiting list, and the public are going to be clambering, aren't they, for, we want healthcare, we want it now. How do healthcare managers, do you think, how do they navigate that difficult balance?
Crikey, that's an interesting question. And there's still obviously a lot of uncertainty, isn't there, in terms of what's going to happen. There could well be a second wave. I think it's a recognition that we're in it for the long term. And I think that what Nick mentioned, in terms of it's a marathon, not a sprint. So investing in the well-being of your staff now, will mean that they're going to be fit enough to take on these challenges. But obviously, what we need to consider are the key issues that were problematic before the pandemic, like not enough staff, like too many demands, like not enough support, and too much intensity. So without a significant investment in that, I think it's going to be extremely challenging for people to face, primary, secondary healthcare, all aspects of health and social care. It's going to be a bit of a deluge, really, isn't it?
That's right.
And the other aspect, I think, is that for the last few months, people haven't been engaging in things like health screening, which is what they would normally have done, things like preventative factors. So, we will be picking up a lot of long-term issues because of that. So, there may be even more demand for that, for services for that reason.
Thank you.
If I could just jump in, I think the other thing also is important, and I think it echoes in some of the points that you make, Neil, is that you need clear, visible leadership that's open and honest to say that, you know, we are going to struggle and we are going to have to draw boundaries somewhere, and we are not going to be able to do everything. And that's communicating with healthcare workers to say, okay, you know, maybe sometimes you have to work a little bit more, or actually this is where we're going to push back and say enough's enough. And then that's also communicating then with the public to say, this is why we've got long waiting lists, to explain why this is. Because I think sometimes, particularly in the public, we have short-term memory to not realize why we're in a position that we're in. And then finally, then that's pushing back to government policymakers and everyone else involved to say, look, we can't be held to the same targets, we need more funding, and whatever that might be. But I think often healthcare workers or just employees in general, if you recognize that your leaders are clear, are transparent, are open, and they're honest, then I think you are more likely to feel that you are supported and you feel that you've got people in your corner.
Thank you.
Okay, any questions from the person? You're all very quiet. I'm wondering whether you're just kind of self-reflecting and thinking about your own situation or your team's, but welcome to make comments. I can see people sort of can see Jane Moore, our central president-elect, on the list. What do people think in terms of the health professionals that they deal with, or is it more about people joining to think about their own position? And, you know, are there any things you think some should be doing? One of the things that I've just been looking at is we just had a request from an occupational health nurse who's kind of very isolated. I think a lot of occupational health professionals do work on their own, and that sense of isolation and what you're talking about, Neil, in terms of peer support and mentoring, that's something that some can do. So we've got a list of doctors who have provided peer support to people on their own. I think it was one of the things people do join the SOM for, actually, is it's often they're working in different settings, and we need to just talk about difficult cases, and it's a place where people can be quite honest and open about maybe things they've done not so well, and it's a kind of, it's actually a shame that we're not having our conference, which would be today, because a lot of the conference, I think, is you know, people just sitting in corridors, unwinding in terms of things that they might not have done as well as they could have done, or just enjoying the work. And the I think people do really enjoy working in occupational health. So admin Nick's just saying, please type your questions in the chat box or unmute your mic and ask. So let's just pause for a moment and just see if anyone's brave enough to pose a question. No. So Neil, I'd be interested in your view about, you know, if you were Perenna Assar, the Chief People Officer in the NHS, and you know, what would you be putting in place? I suppose from our perspective, you know, we are concerned about a number of staff who are off and are not being risk assessed in terms of their vulnerability properly. So there's a kind of occupational health issue rather than a sort of mental health issue. But it does seem that NHS is spinning off into making kind of quite poor decisions in terms of COVID vulnerability, and many staff are off when they don't need to be. But perhaps that's a separate issue. But, you know, if you were in the hot seat, what would you be asking for?
So I'm part of this, say, it's NHS England an improvement wellbeing team. So Brianna obviously owns that. But Em Wilkinson's her deputy, and she runs that group with Sonia Warbank, who's been excellent. And you know, I'm an outsider. I don't work for the NHS, so I don't really have, you know, I'm not politically, I can say what I want because I'm not bothered. But I really do think that the talk they're talking in there is positive, in that they want this to be an opportunity to, you know, to make the NHS that they're saying the best place to work in, and that people want to come and stay there. And I've been around long enough, I'm sure most of us have, you know, that you hear lots of this great talk and you think, well, yeah, that sounds all really good. But what actually comes out of it? But there is a plan, And that plan, if it comes to fruition, has things in it such as, getting people to healthcare workers to access formal mental health care within a few weeks, rather than waiting 6 or 9 months, which obviously is a known goal if that's the case. So that is in the plan. They released just today a whole series of resources for leaders, so that if you're a leader in the healthcare setting, you can have free mentoring and free coaching, which is pretty good. If your trust doesn't provide it, it's now available. There's 3 different groups who can provide it. You can choose what you want. It's one-to-one. One of the ones is the Army Centre, which I think is quite, so that you can choose what it is that you want. There are plans to do this monitoring. One of the things I'm doing with my company and the NHS made, well, they are going to do it. It says is to provide this supervisor training remotely for supervisors to try and help them have psychologically savvy conversations. So they have definitely got a plan in place, which, if it comes out, actually should help create that environment of actually we are in it all together. Of course, what I don't know, and I guess none of us know, is in the new economically downturn world, is what gets, do those things get turned into actual proper offers? I think one of the things that will happen actually, and I suspect NHS people know about this as well, is you would imagine, wouldn't you, after a war, that people wouldn't want to join the military, that somehow, if you see lots of deaths, in fact, the opposite happens. So when the more the death toll went up in Afghanistan, the more that actually young men and women, decided they wanted to join the armed forces to get a bit of action, if that's the right term. And actually, I'm pretty confident, and there has been some evidence about this already, that actually people have been infused by this. They want to go into healthcare. When I was at the Nightingale, I made a point of being at the don and doffing station when people came in and out to chat to staff. And I remember speaking to these people who are clinical scientists who normally most of the time measure hearing and gait length, and they were on the wards doing clinical stuff, and they were absolutely buzzing. They loved it. And one of them, I'm going to train to be a nurse after this. And so I do get where the Daily Mail, which I don't like, comes from with all this doom and gloom. But I think from an NHS England point of view, they really have got an opportunity to actually, I'm not sure about making it the best place to work, but to turn it from a place that you'd never really wanted to work if it wasn't for the caring for patients into somewhere that actually is pretty good. As I say, what I don't know is does that turn from nice rhetoric into actual action? But there is a plan. You're muted.
Yes, I think it's interesting, sort of leading on from what Neil said, about the fact that nursing, the numbers for nursing students applications have increased considerably since the pandemic. So that's raising the profile, isn't it, of nursing as a healthcare, desirable profession. So that's quite beneficial.
Yeah, and I don't think there's enough discussion. There is a bit, but there's not about people who are thriving, because resilience, whatever that term means, at community and organisational and team level, I think is very much about actually. I never thought I was going to get the opportunity to work with the same bunch of people doing this amazing stuff, and we're doing a study at King's College London called NHS Check. So we've got about 6 hospitals across the UK, most in London. And we've only got about 5,000 respondents. We're trying to get the rate up and the rest of it. But certainly when you look at some of the comments, some people are finding this to be, an amazing experience. They didn't think they could cope, and they did. I remember on that point, we did some work after the Ebola crisis, where Public Health England sent out a whole lot of laboratory staff out to West Africa to help with the Ebola response. So I don't know how many of you sort of know laboratory scientists at Public Health England, but they're probably not the sort of people who are going to parachute behind enemy lines, to take out the enemy. That's not what they do. And I remember speaking to one of them. We were doing some qualitative interviews, and this guy had spent 20-something years at Important Down doing PhD research, and he said, I didn't really think I could make it, but I've done a really good job, and I'm making a real difference. And he was just so excited and so I wouldn't want to overplay the success and wonderment, but I do think that we are sometimes wrapped up a bit too much into 70% of these people are distressed and this and that and the other. And of course, in the general population, levels of distress and anxiety are going to be high anyway because we're in the middle of a crisis. So it's hard to know what normal is.
Okay, I've got a question from Karen Shisha West to everyone. So I think what she's saying, Karen, you're welcome to put it yourself and unmute yourself, but you're saying that it's just really the time to take breath and reflect, and often there's not permission because patients are there, you felt that moral obligation. How do you advise people to just kind of carve out that time, say, you know, I'm not going to see that patient, I'm going to look after myself? It's a kind of internal self-care thing, isn't it? I mean, I presume there's permission from the kind of powers that be in a sort of healthcare environment for people to take some time out to kind of go and see their peer mentor or whatever. So it's just that giving yourself time, permission, and the dichotomy with actually, well, I'm not going to see that patient. You know, they can, you know, whatever, not have that cup of water, whatever. I'm going to just have a chat with someone about how I'm feeling.
I think on that point, I mean, I think it's difficult in the middle of a clinic to take time out because you've got 20 people to see in that time. But I definitely think that, you know, into the working week, supervision and reflection should be part of our day-to-day practice. Because, you know, we're asked these days to have, you know, reflective learning, reflective practice. We're meant to reflect on things. That's what we have to have in our appraisals, and certainly as medics. But actually reflection best comes when you do it as a team, and people can own their mistakes and their successes together. And all the evidence from the Schwartz round approach is it's not just about people chatting about it. It's having a leader, you know, start the discussion by saying, I didn't get it right. You know, when I was at your stage, I got it wrong far more than I ever got it right. And to give people that psychological safety to have those conversations. But it has to be timetabled in. I don't think you can, you know, not go to the crash call to get a bit of reflection. You know, that probably wouldn't be right in my view.
Absolutely. And it's vital for staff to be encouraged to take annual leave, because I'm sure there's been a huge amount of annual leave accumulated through the pandemic. You know, a recognition that people will just burn out unless they have adequate opportunities for recovery. So, you know, you may look at it in the short term in terms of staffing levels, but over the longer term, it's going to be far worse. And also role modeling the behavior, desired behavior as well, making sure that managers and leaders do prioritize their own recovery and their own well-being. You know, so I think.
I mean, I'd like to think that, I mean, just from some personal experience, that, you know, because we're kind of looking into each other's houses and being a bit more honest about how we're not feeling that great, and we're seeing what's going on in the background, people being a bit more relaxed about what they wear, there's a bit more honesty creeping into sort of management and leadership, and you know, what you're saying, Neil, about people just saying, well, I did mess up here. And I'd like to think that that's happened, but I mean, there are still concerns, aren't there, in terms of the impact of the pandemic, in terms of, as Gail was saying, sort of new starters and people coming into the team. It's less easy, certainly if it's remotely. I mean, for healthcare professionals, maybe it is easier. And just on a kind of infection control thing, I mean, I think one of the things that we have been discussing with the Anaesthetics Association and Infection Prevention Society is that a lot of the infection risk now is not, you know, during a ward, you know, on the ITU. It's when people are, you know, doffing, then going to have a cup of tea and they have a hug and stuff, and bang, you know, there's your infection risk. So there are kind of moments in the sort of what we're looking at in terms of the bow tie approach, which is getting some interest, which actually are risky in terms of COVID infection. That you know, you can't have that hug. You know, maybe you shouldn't have that cup of tea, and instead you should sort of, you know, make sure your clothes are going into the washing machine, etc.
We're just doing a piece of work actually at the moment from our health protection research unit. We got on nosocomial infections, which are exactly that, about infections acquired in hospitals. And the worry is from SAGE, you know, I think this is public, you know, in some, that actually it's been healthcare facilities and care homes that have been, you know, seeding a lot of the infections back out into the community. So we did a big review of looking at nosocomial infections, and there was, you know, Sam Brooks, who I work with, is amazing. She's just got off on maternity leave. What a loss to systematic review at the moment for 4 months. But she did in a couple of weeks put together a 94-page report, because there's so much information out there, much of it which is conflicting about what the risk factors are for hospital-acquired infections. But when we're just doing a survey at the moment, which we've got some funding from the Chief Scientific Officer for, because there really is a feel that actually, as tough as it is that healthcare professionals are not paying the right amount of attention to that. And actually, it's not the people in intensive care. Actually, it's the ones around them. It seems.
Yeah, that's definitely what. As much as it's testament to the anaesthetist that they're still concerned, even though I don't think any anaesthetist has died from sort of COVID-related infection. And when we had a meeting with Bob Goddard, at President of RCP, it's not the ITU, it's these, as you say, the care homes and other settings where there's risk.
Yeah.
Okay, well, look, we're really, I think we're out of time. I'm just looking at final chat comments. Gail's put something from the BPS about guidance for healthcare leaders and managers. Nick Llewellyn, thanks to Nick for hosting this Zoom for us, just saying full recording will be circulated to registrants after. And thanks from Amrita and Pat. Any final reflections from Neil, Kevin, or Gail? I mean, thanks, great presenters. It's very, very useful. Thanks so much. But any final comments? Send us on our way.
I think what I would say is that, kind of echoing what I was saying earlier, there's a lot that we know, but there's also a lot we don't know. And I think as we move forward, we need to recognize that we're going to get things right and we're going to get things wrong, and that there'll be fundamentally we can communicate with each other, learn from our mistakes, and be open and honest with what's going on, the state of the research, how we feel, how our colleagues are feeling, and I think that will probably be a good point to start with.
Thanks, Kevin. Gail?
Well, I think, to be honest, Kevin has said it all, that we do need to be open and honest and use this as a massive opportunity for learning, like a case study. It's happened, and it was sudden. It's tested a lot of the systems, and it's actually exacerbated existing problems in the system, and it's added a few more, for good measure. So I think it's an opportunity for us to learn and put things in place and remedy key issues, but also to celebrate the fact that people have continued to cope, like Neil said. So focusing on the success stories will allow us and enable us to make improvements in terms of what works and provide guidance for the future.
Thanks very much, Neil.
I guess the only thing I'd end up is just saying, of course, healthcare workers are also part of the general population, and that whatever we know about the impact of crises like these, the economic downturn in 2008 was associated with increased rates of depression and suicide. So we've also got, more than 3,500 people have been discharged from intensive care units. 20% of them are going to probably have PTSD. Who knows about the Prime Minister? And then we've got a whole lot of bereavement that's going on. So I wouldn't just focus on the healthcare aspect. There's also the whole general population aspect, which is obviously relevant to all of us. But yes, to finish on a positive note, I think we should absolutely be going for growth. And I think that if we can view this as an opportunity to get things that weren't right into a good state of being for the future, then actually, some silver lining has come out of this horrible COVID cloud. Yeah.
Thanks, Neil. I mean, it's interesting. Someone just put a comment saying there's not been many questions because you've covered it all. I do think that's the case. Quite a complicated area, and you've all three. I mean, we're very lucky. You've cut through it and presented fantastically. So thanks very much. We couldn't have got better people. And everyone, have a cup of tea. Think about yourself for a bit. Look after yourselves. But thanks to our speakers, and we'll be in touch. You can see the contact details for Gail and others on the chat. Thanks, Neil. Thanks, Kevin. Thanks, Gail. It's a great job. Okay. Have a good afternoon.
You too. Bye-bye.
Bye.